Here is a case of large volume stone with multiple stones, that too in the pelvic ectopic kidney, where flexible and navigable access sheath is used in 43 years old male patient, right abdominal pain, 1 month, pelvic ectopic kidney, 20 into 15 into 14 and 112 large renal calculi are there. You can see all of them are at the sacroiliac joint. Very difficult for we can do lap, but these small stones may not come with lap pyelolithotomy. So when see, you can see the stones in CT, 4 stones are there, and this anatomy looks dilated, but for puncturing bowel will be there. Lap assisted we have to do. When you go into the ectopic, you can see how big the stones are. But when the flexible scope can reach, these are hard stones. Now access sheath is placed and very fast powdering is done with 1 watt and 15 Hz, 200 micron fiber. And with this, complete powdering is possible, and powder can be sucked continuously. And then one more stone is attacked. Even if you make some fragments, you need not worry. You can use fragmentation method, or at the end popcorn method, to suck out all these stones. So the main idea is that whatever the stone that is visible, if you make powder, it will be sucked spontaneously while doing the. It will be useful, especially if the calyx is localized and stone is big. If it is not in the pelvis, if it is not dilated system, it is very, very useful. Even in dilated system, partially you can collapse the system and keep the vision very clear. And last but not the least, because suction is continuously applied, the temperature also will be low in the PCS. And one more thing, you can use the pump also at a lower this thing, so that continuous suction also can be used. Then it will become exactly like TURP Iglesia system. Then you need not have any assistant for flushing. Just keep on going. Only thing is that suction and irrigation must be perfectly balanced. It's not that suction person will forget and the irrigation will going on. That is not correct. Even then water will come out through the access sheath, but pressure will rise. So manual irrigation or by gravity irrigation will not be sufficient to keep the system distended. If the system is not distended, it is not good. Multiple laser burns will happen like this. See, now surgery is done. Now suction will be starting. Initially, scope need not be removed front and back. Do as much as possible. At the end, you can suck it out. That is more effective, because at a time more fragments can be sucked. From the beginning only, if you do removing, putting, then blood can come. So the ectopic kidney, this large volume, very difficult to plan PCNL. Even with experienced hands, some of the stones may miss. See, whereas here, small infundibula, even then at the mouth, the access sheath is kept and they are sucked. Only thing is that you should not force this access sheath into the obstructed ureters, obstructed pelvis, obstructed infundibula. That is the only thing. It is a basic skill which comes those who are doing RIRS, not a really difficult job. Second important point is, don't try to bend the access sheath with flexible scope. Better go with flexible scope with calyx and thread it. That is very, very easy. And during threading, ensure that you have adequate lumen to thread it. See, this is a picture at the end. Complete clearance was possible. In fact, CT is also done in this case, showed near clearance of this stone without any fragment. Maybe 1 or 2 mm stones may be there. And that is the aim of the fans with RIRS in this ectopic kidney. Thank you.